I'm Tom. I'm a PEM consultant in Belfast and a senior lecturer in paediatrics at Queen's. Um, that photo's not that long ago. It's been a bad year or so. Right. Anyway, and then Costa. So I'm gonna do the first half, and Costa's gonna do the second. You should have that already if you're on Slido. But if you're not, that's just for the paediatric emergencies thing. I will say the feedback code for this is on the slide with the diagram of smooth muscle. So keep an eye out for that. And it means if you're just trying to watch this back and skim to the code, it'll be difficult. So the code for the feedback is on the slide with the smooth muscle. So keep your eye out for that. So my aims are to go over the initial assessment and management essentially of a child with sepsis. Um, and then so that's what I'm going to do. And then Costas is going to do the second part. Um, just put this, and this is our department in Belfast. This is on a social event. This is not in ED. But I suppose I'm going to make the point. I feel I'll probably get in trouble for this, but we kind of do a bit of everything. Um, so I'm not going to be talking about, my talk isn't going to be that you need point of care ultrasound or central lines. I'm going to talk about what you do really in A&E. And if you have some of these specific skills that make you superb, then that's brilliant. But my talk isn't going to be about them. I'm going to be a kind of jobbing tradesman who's going to do the job and hopefully resuscitate the child. Don't be this guy. The name escapes me, that the teacher from the dark arts from Harry Potter who says he can do everything but can't do anything. So do the basics really well, and that's kind of the aim of my talk. So it's a 6-year-old. I'm going to build it around a case. I've got to thank Costas for the case, and he'll give you a bit more of the end information at the end. They're known to have febrile convulsions. They're fully vaccinated, and I've had a bit of a sore throat. High temperature, a few days that hasn't really gone away. They had a short febrile seizure outside the GP practice. And so they were sent up to hospital quite rightly by the GP, and they were given, because we've heard already today about how important it is to give benzos early, the excellent pre-hospital paramedic crew gave midazolam, and because they gave it so quickly, the seizure terminated. The initial assessment in A&E resus is that they do have an airway. The SATs post-seizure are coming up, and and the heart rate is 168. The cat refill's prolonged. They're cool around the edges, and they're not really responsive, but they have just had a seizure and have got equal reactive pupils, 3 millimeters, and their blood sugar, as we expected, because we've been hearing about high blood sugars, is a little bit high as part of their stress response, and they're very hot. And you notice that they have a widespread rash, a bit sandpapery, a bit rough feeling. They have petechiae, just a bit of conjunctivitis, and quite a red-looking tongue. So petechiae and purpura, we can't just talk without sepsis without putting them in. So petechiae are small, typically pin dots, less than 2 millimeters, and purpura are much larger, typically like bruises. Petechiae on their own are very weakly associated with meningococcal disease, and that's even if they're spreading. And my paper's in there if you don't believe me. But whereas purpura and fever are typically synonymous with meningococcal disease, a far less common presentation and a far more worrying one. So with that in mind, on the slider, what do you think the most likely cause of this child's raging temperature, seizure, and just kind of moribund appearances? Okay, yeah. So haven't people changing their minds? Look at that, and there's like more people even waiting for oh, maybe it's toxic shock. Okay, so what's the most likely? So you're adjusting around meningococcal. I kind of led you there with a non-blanching rash. Actually, this child's born after after 2015. So we've got to remember meningococcal C vaccine 1999, meningococcal B 2015, and then we also had AC YW came in as well, although that's not until older children. So we see far less meningococcal disease than we used to. We also see very little pneumococcal. So actually now invasive group A strep is more common. And this syndrome, this pattern is a fairly typical description of someone who's perhaps had a sore throat, scarlet fever, and progressed towards a kind of streptococcal toxic shock. But all worth considering. So group A strep, so it's a gram-positive cocci, so you get them in chains. It's beta hemolytic, And that's all the ID uh, you ever need to sound clever from an ED point of view, at least. Remember, we're not we do a bit of everything, and it causes lots of different disease manifestations. So it can cause local disease, so sore throat, tonsillitis, cellulitis, erysipelas, um, uh, so that's local disease, local infection. You can get your exotoxin mediated disease. That scarlet fever is a mild form of an exotoxin mediated disease. And most children with scarlet fever recover very well with oral antibiotics, but very rarely you get this streptococcal toxic shock syndrome. And then you can also get post-infective autoimmune conditions, such as a post-streptococcal glomerulonephritis. And thankfully in the UK, it's extremely rare now, rheumatic fever. So streptococcal toxic shocks is probably under-recognized. Mortality is much higher than its staphylococcal friend. Vast majority end up in ICU, and its treatment is slightly different from sepsis, although we're going to predominantly talk. It isn't so far different that there's just a few nuances. Invasive group A strep is seasonal, and with peaks at extremes of age. Peaks are usually January and March time. Mortality can be 20%, and we certainly had bad invasive group A strep not in the previous winters. And IGAS is not just toxic shock, as about a 1 in 5 admission rate, with about 1 in 4 needing some sort of surgical intervention. And most of the ones we've been seeing or have seen are nasty pneumonias with empyemas. So not all non-blanching rashes are due to meningococcal disease. Group A strep, we talked about. I mentioned invasive meningococcal disease and vaccines. Gram-negative sepsis. So any sepsis, if you're sick enough, you'll get you'll get DIC and you'll get non-blanching rashes. And then also consider that child who has perhaps been tired, run down, some unexplained bruises or spots, who's come in with a viral illness and actually may have malignancy, or they could even have a neutropenia and secondary infection, although that is thankfully very rare. So initial help, this management of this child, you're going to need some help. You're going to move them to an appropriate setting, and that actually is quite important, moving someone to the right place. You heard Diva Mullen talking about resource use, and sometimes if you have a child who is sick and you want to dedicate resources and focus people's attention, that physical movement to resource can do that. You need access, and you're going to send some bloods, including PCR. And PCR, actually, I'll mention that here, it's really important. So particularly things like meningococcal, only about 50% is blood culture positive. And we've got that from the paper I mentioned previously. PCR, if you've got it available relatively quickly, it's far more sensitive. Give some fluid boluses, you're going to give some antibiotics, and you're going to reassess. We haven't said much about those because we're going to get your thoughts on those bits. So, which fluid bolus do you want to give for this child initially, a 10 or a 20 ml per kilo bolus? Okay, I think that's enough. So, vast majority going for 10 ml per kilos. So I know why you've done that, and we're just going to go a little bit into the background. So we go back 20 odd years. Early goal-directed therapy was all the rage. And there was talks of people giving 60 mils per kilo, and a lot of this is adult research, which gets extrapolated to children very, very quickly, and at getting central venous monitoring very, very quickly. And there were some very good results reported, but it was very team dependent. And people were very interested in this. And then the FEAST trial came out in 2011, also in the New England Journal of Medicine, which was looking at giving fluid boluses to children in 3 countries on the African continent. And they got 20 or 40 mils, and they got different fluids, and had to be stopped because there was increased mortality in the fluid bolus group. It's probably worth noting that very few of those actually had sepsis. There was lots of malnutrition, lots of malaria, lots of anemic children, and not access to ICU. But it was enough to cast some doubt over whether just use of fluids without thought was a good idea. And then systematic review, looking more at adults, but showed that, to me, really confuse things. Greater survival if you give more fluid in the first 3 hours, but lower survival with more fluid in the first 24 hours. And I'm going to explain a little bit of the physiology and go through a little bit of this. But essentially, um, if you're hypotensive, and there are various ways you can manage that, you can use different tools, fluids being one of them, to maintain perfusion, which is what you're trying to do. But we've heard, and Chris talked about it pretty well in his talk. He said these things are temporary. There's a limit to what you can achieve with them, um, before they become harmful. So it's not so much the volume, it's knowing that there is a limit to what you can achieve with fluid. You will not fix a very septic child with no peripheral vascular resistance, poor cardiac output, just with fluid. So to answer that question, the 10 or the 20 actually there's not a right or a wrong. I think the thing is about reassessment, and I'll talk a bit more about fluid refractory shock. What you don't want to do is not give enough fluid, and also you don't want to give too much. And there are ways of monitoring that. And I don't mind if you give 10 and reassess and give another 10 very quickly if it's needed. This child will need more than 10. Or if you give 20, but ask someone to remind you, or you set a system for monitoring them or reviewing them partway through the bolus. What you don't want to do is give a bolus, have long periods of time reassessing, and then decide to draw up and administer another bolus. So in resus, I'll often say, I'd like you to prepare the 20 mils per kilo bolus, give 10, ask me, we'll reassess, and then we'll go straight with the next 10 as a compromise way of essentially providing some sort of monitoring. So which fluid do you want to give? There are other fluids available. They're just ones I put in. Hass's human albumin solution. Who wants what? Let's have a look. So lots of people. So I wouldn't give albumin. You may need it, but not yet. This child has no fluids yet. Oh, don't you have to change your mind? I can see it going down. For the first bolus, I actually don't mind whether you give saline or plasmolite. I ticked plasmolite as the correct one. I think if you're going to use large volumes of fluid, using a balanced solution, plasmolite, Hartmann, Schwinger's lactate, is preferable. I'll explain why. But also human factors. If your department stocks normal saline and the nurses are used to it, and that's your first bolus, one bolus, in my opinion, of normal saline isn't going to be the be all and end all. But if you're going to give large volumes, you should start thinking about balanced solutions. And you as a team leader can do that. Because again, we've talked a bit about human factors. You don't want to be complicating things if you can avoid it. So I'm glad no one mentioned blood products. Blood products are often needed, but are actually harmful if they're used initially. So once you hematolute, you're going to need to replace packed red cells, platelets, coagulate, and coag factors, but you don't need to do that. Crystalloid, absolutely fine initially, but just think about balanced solutions. They're not harmful. There's less AKI in adults. There's less death in adults, and you're less likely to have hyperchloremic acidosis, which I believe for my colleagues in ICU is annoying. So we want to try and help them as much as we can. So if you're going to go beyond that 10 to 20 per kilo bolus, start thinking about balanced solutions. If your department could do it from the off, even better, but don't be delaying things. Okay, which antibiotics do you want to use? All right, so a bit of variation. So first of all, you haven't got a choice about the third generation cephalosporin. You're going to need to give that because it's pediatrics. It also penetrates the CSF and it's very effective. Out of the two, ceftriaxone and cefotaxime, my preference would be cefotaxime if they're very sick, just because you can give it much more quickly and it doesn't have the same issues with calcium through the same line. I think clindamycin in this case, if you've made a positive diagnosis of streptococcal toxic shock, or you think it's very likely, is a really good shout. Gentamicin is reasonable, but I wouldn't, without clindamycin, I think it's useful if you're thinking gram negative, if you've got a renal or intra-abdominal suspected cause of your sepsis. And I would keep an open mind, and I may be the only one that does this, but if someone's very sick, even if I think they have a focus, I have no issue asking surgeons or for an ultrasound to look for other causes. Intra-abdominal causes are easy to miss in children when they're very obtunded. So I've mentioned this, but that's just reminding you. So with third generation cephalosporins for CSF penetration, you can give ceftriaxone fast, and I've done that as well. Again, you don't overcomplicate it. Do what needs to be done to get the antibiotics in, but just remember the issues with calcium. I think cefotaxime is a better choice, but it can cause some confusion if you're not used to it. We've talked about gentamicin, metronidazole, and clindamycin. So clindamycin, it's the reason we want it is, I should have done this as a question actually, but it's bacteriostatic and it reduces toxin production, or that's the argument. The other medication we can use is IVIG. IVIG is not a resus drug. Just in case anyone didn't hear me, IVIG is not a resus drug. It is really useful, but it's not a resus drug. Clindamycin is very good for toxic streptococcal toxic shock. And as that table there basically says, if you give clindamycin with or without IVG, whatever you do, your mortality is reduced by giving clindamycin. So clindamycin is good. IVIG is not a resus drug. So progress. So the child becomes more acidotic, lactates up, their calcium's a bit low, the cat refill's still prolonged, they're still a bit tacky, and their blood pressure, at least you've got a blood pressure, because often we don't get one, is in their boots. And that's after you've given 20. You might have given 10 and 10, or you might have given 20 straight away, and you've given your antibiotics. So we're now in fluid refractory shock. And these are the things that we can do for fluid refractory shock. So we can give more fluid, and we can give lots of fluid in the first 30 to 60 minutes. We can correct the hypercalcemia. We can give vasoactive drugs, and we can also intubate and ventilate. And that's, I'm going to let that come in the next talk, but sometimes actually taking complete control in that way can you almost see that like they've given another inotrope. I know it isn't, but you sometimes see a big improvement. So fluid boluses, we can give up to 40 to 60 mils per kilo. You can actually give as much fluid if you need to, but beyond that, you're going to be needing to really think about monitoring in the first, you want to be trying to give that in the first 30 to 60 minutes. So if you are giving fluid and they really need fluid, you should be assessing and you should be giving it in 10 mil per kilo aliquots, but you shouldn't be, there's no situation where restricting fluid early in resuscitation has ever been shown to be beneficial. And this comes from the International Sepsis Consensus Guidelines, 10 to 20 mil per kilos, 40 to 60 mils in that first hour. And the paper's there. So correct the hypercalcemia, so you can give calcium gluconate or calcium chloride. The doses are in the Paediatric Emergencies app, which is incredibly useful. You all know this already, but just for a refresher, so half your calcium's ionized, the other's bound to proteins or bound to anions. When you have a bacterial infection, you will often be hypercalcemic. PTH, the parathyroid, and the parathyroid hormone function is impaired. Unfortunately, it's not as simple as just giving everyone calcium, because hypercalcemia is also bad, and there's some adult data. If your calcium's overcorrected, actually can affect mortality as well in the longer run. This is the slide with the smooth muscle in bottom corner if you're looking for the code. So this is you'll have adrenaline. I was thinking about how does calcium work, or what's the effect. So this is adrenaline here. I made this actually, this diagram. A calcium channel. You get increased calcium, intracellular calcium entry. That activates your myosin light chain kinase, which phosphorylates myosin, and then you get, remember, your myosin actin cross bridging from kind of sixth form A level. So calcium isn't an inotrope. If you've no calcium, it's very hard for this signaling to work. If you've got adequate calcium, this will work really well. And having too much calcium probably doesn't do anything because you've got enough calcium. And calcium has lots of other transmitter roles in lots of different parts of the body. So it's not just more is better, it's just having enough, the correct amount of ionized calcium. So peripheral vasoactive drugs. So I've written peripheral. There's a place for central lines and centrally given drugs, but that's not what I'm going to focus on. I think it very much comes as part of Stephen's talk, which you've had already, stabilization. I'm not a big fan of someone trying to very early in the resus get a central line unless they have a very particular set of skills. So a few pictures you may have seen already. So remember the dead space, that's that picture on the left, and Chris discussed that today. Go and check. It can take the same for the setup there, 27 minutes to reach the patient. Start adrenaline early if you know it's going to be required. So there was a question earlier about do you have to wait? As your experience grows, you will know whether a child is likely to respond to a small amount of fluid. And if they're not going to, I would be getting my inotropes prepared whilst we're doing the basics well and starting them. And I would have no issue starting them after 20 ml per kilo bolus, personally, if they're needed. You can give push adrenaline, dose adrenaline if you're stuck, and that's that 1 in 100,000, 1 mics per kilo that we talked about, where you can dilute 1 milligram up to 10 mils. Sorry, you can get the mini jet and dilute it 1 mil into 10 mils. Or you can start an infusion with 1 milligram and 50 mils at 0.3 mils per kilo, which is that 0.1 mics per kilo per minute that Chris had talked about in the inotropes talk. And then a bit of physiology again. Just, I know you know all of this, but what have I done wrong? Okay, now someone's saying about my biology teacher and the messages. So blood pressure, cardiac output, it's not exactly times, it's cardiac output and vascular resistance. So we go back to kind of why we need fluids, why we need what we're trying to achieve. And cardiac output's your heart rate and your stroke volume. So adrenaline, noradrenaline essentially can work on different parts of these. So adrenaline, I like because it's easy and actually for something quick, most of our children are cold shock, and they need their blood pressure supported by cardiac output and vascular resistance. So I get the alpha and beta effects, I get a higher heart rate, a larger stroke volume, and I get some squeeze. Noradrenaline is more alpha effects. We're going to get the squeeze, but we're not going to get so much cardiac benefit. And then we think about fluid. So essentially, if you've got vasodilated wide vessels, the volume of fluid that's in there, you're not going to have blood pressure. So you can temporarily restore perfusion and blood pressure with fluid, but it is going to leak out of that circulation. You can try and restore it with drugs, or you can use a combination of the two, which is why if you need to restore blood pressure and perfusion quickly, you give fluid quickly, you start inotropes early. No one of these on their own is going to be the complete fix. You're just trying to support that child through that illness until your antibiotics or other treatments actually result in cure. So you're just trying to support and get through without causing so much harm as well that the team after you can't manage them. We go back to the fluids arguments. We might get them through resus, but then the fluid management is a real issue in ICU. So I think trying to understand fluid isn't harmful. It's just a tool in what we're trying to achieve. And then fluid refractory shock. So the last part's taking over their airways, and that's where I need some help, and I can't do that. And that's coming up to my kind of 30 minutes just on there, and that's where I want Costas to come and give me some help.
You're lucky enough to have Picky on site with this patient. A brief recap on the case. So Chloe's 6, and we think she's got a sore throat, probably group A strep, toxic shock syndrome. She had a seizure outside the GP practice when she was walking out with her antibiotics. And also, when Picky arrived, Mum said she's injured her head on the step as she was fitting. A bit of blood on the head. Looks quite superficial, but a bit of a worry. So when we arrive there, these are her observations on the screen. So I'll give you a second to digest them. Please take a screenshot on the gas, and then we'll see what worries us about this gas and about these observations, and we can try and solve the case together to try and see if we can get Chloe to survive. So together we'll formulate a plan. So we will address airway breathing circulation and disability and exposure. So this will be done through Slido. What's the single most worrying feature of Chloe's capillary gas? So let's try and brainstorm. Okay, pH, acidosis. The lactate, yes, the lactate is a bit of a worry. Okay, low calcium, yeah, that's a worry. The CO2. Okay, lots of good stuff. Right, so I can't see the YouTube responses. So if Tudor can answer me, if anyone wants to comment, does the normal blood sugar worry anyone?
So online lactic acidosis, respiratory acidosis, and mixed acidosis.
Okay, so an unpopular, and this is slightly advanced blood gas interpretation. And you're not going to find this in the books. You'll find it from spending time on next to the patients in a critical condition. My most worrying part of that gas for me is a child that sick with those observations having an entirely normal or a low normal sugar. So it's on the lower end. So that suggests to me that this child has already exhausted her adrenergic response. It's a subtle feature, but it's one that is worth pointing out. She's not a baby, so she's 6, so she's got enough stores there to be able to mobilize and increase the blood sugar, and those have been utilized already. So in low normal blood sugar in a child with septic shock is a considerable concern, because it suggests that with someone who's already used their catecholamines, their own innate catecholamines, and they are likely to arrest very soon because they don't have any more reserve. So all your answers are correct. Lots of worrying features on that gas. The numbers do not make a pretty read, but what stands out for most experienced frontline physicians that deal with emergencies is that blood sugar should be much higher. She should have enough stress response there for her to have a blood sugar that's 9, 10, 11, and it's not. It's about 5, 4.5. I can't remember off the top of my head. So that is a subtle but very important point, because it will allow you insight as to how to prepare sooner, and it will also help you prepare for intubation slightly differently, because you know that you probably need to have your inotropes ready before you intubate her. Okay, we need to intubate this child, so I'll give you a moment to see what the best choice or the least bad choice is in terms of how we intubate her, although we've got a clear front runner. So you've chosen the correct answer, and let's dissect it. So is the choice of paralytic important in this situation, and if so, why? Can anyone on the channel tell us about it? Why do we want rocuronium over succinylcholine, or is that just a whim?
So we've got an answer here. Sux has you get bradycardias and raises potassium.
Good, good. So that's a ballpark correct answer. So we need to know the illness to beat the illness. We need to know how this disease is going to behave. So we have a child whose potassium is already high on the gas. I think it was about 6.2 or something. And we have a child who is likely to get acute kidney injury secondary to the sepsis for a number of reasons, generally pre-renal failure to begin with. Giving succinylcholine will cause further potassium release. If she needs blood products as well later, they are potassium rich because we use potassium citrate to stabilize blood. Again, we are particularly going to give more potassium through blood products. So if we give Sux now, we are risking this child arresting on induction by causing an acute hyperkalemia, and I've seen this happen. So even though succinylcholine generally has a faster onset of paralysis, which is favorable in some situations than rocuronium, merely by doubling the rocuronium dose, which is a much cleaner drug than Sux, we can get a quittable fast onset of paralysis. So rocuronium is superior to Sux in this situation because it's a safer drug to use. Equally, propofol is quite a dangerous drug to use in very septic, obtunded children with shock because it's a potent vasodilator. And the last thing you need in a child with warm shock is to vasodilate them further, because you're going to drop the blood pressure, and by extension, they're going to arrest on injection. Which then brings us on to the reasoning for why we need a cuffed tube. Can anyone in the group tell us why we might prefer a cuffed tube to an uncuffed tube?
I think you really want to intubate once and once only. And if
Absolutely.
you should up or downsize the tube, that's no good.
Yeah, so excellent. So cuffed tubes are quite forgiving. You might be slightly off with the slightly off with the sizing of them, but all you have to do is put some more air in the cuff, and then you have a tighter seal around the airway, which will allow you then to ventilate better. If you have too small a tube, you won't be able to ventilate a child that is likely to have very high ventilatory requirements because they have sepsis. So you don't want to be reintubating and exposing this patient to more risk by having to tube them again. And also you need to work smarter, not harder. So by using a cuff tube to begin with, you make less work for yourself. But more importantly, you're taking some of that risk away over intubation from Chloe. Which then, once we've done the tube, then ideally we would have pre-optimized for the tube, and we would have started peripheral adrenaline to begin with. We need to decide how we ventilate her. Okay, now how are we going to do that? A slightly more advanced question, but you are likely to need to hold the fort until PICU arrive if you don't work in a big center. So this is stuff that you need to have some basic understanding of. So I think what we're seeing on the screen now is a good example of confirmation bias. Because, I mean, the right answer is gaining ground, but the right answer is not the one that 63% of you have answered. It's the second one. And I'll go through my reasoning now. So again, back to basics. We need to know how the illness will behave in order to beat the illness. So we have a child with fulminant sepsis. With fulminant sepsis, we get a considerable amount of vascular leak. There's increased vascular permeability, and you're going to give a lot of fluid. So the combination of that means that the lungs are going to be flooded. When the lungs get flooded, you get lots of pulmonary edema. And when you get pulmonary edema, ventilation becomes very, very tricky. Now, the best way to displace that fluid from the alveoli is to have a higher PEEP. Okay, and remember, oxygenation happens during the inspiratory phase. So you need slightly longer inspiratory phase, so a higher I time than usual, so 1.2, in order to keep those alveoli stented longer. So you need a higher PEEP of about 10, because that stents your alveoli that are more prone to collapsing because of all the fluid, and keeps that fluid out to allow better oxygenation. Now, with that comes the risk of changing your intrathoracic pressures enough that it will affect your blood pressure in a bad way. But you're already on inotrope, so you need to be ready to mitigate for that and ride it out with more inotrope and possibly more fluid. Okay, so you need to go on. Most people will start on a PEEP of 8, and that's entirely reasonable, and then titrate down or up as much as the child allows you. The risk with low PEEPs is that the alveolus collapses, and when it collapses, the energy expenditure needed to reinflate the alveolus is significant and causes a lot of arterial trauma and predisposes to more lung damage. So in terms of how it affects your patient is going to be much worse for both the acute and the long-term outcome. Okay, so the principles here, we have a high PEEP strategy, a high I time strategy. This child was very difficult to oxygenate, and even those very high settings, her SATs were about 75%. Okay, so I've not put this as a formal slide or question, but you have a child who's on very high PEEP strategy. We ended up on a PEEP of 15, 16, I think, which is not something you should be doing without support of a PICU right next to you. And FR2 of 100%, high I time, and the SATs were still in the low 70s to mid 70s. So what can we do to try and oxygenate this child more, or to try and make her survive? Again, I can't see the text, so if one of you guys or girls tell me about it, that would be lovely.
So can try APRV or high frequency.
Yeah, so I need to move this child from a
Sorry,
small hospital
oscillation.
to a bigger hospital. So an oscillation would be not unreasonable, but I can't do that whilst I move. APRV again, it does have its utility for retrieval, but it has been shown in more long-term studies using PICU that we don't use APRV well enough in PICU, so mortality is higher. I think part of that is us not using it correctly yet as a community or PICU, but the adult intensivists use it to good effect to the extent where they got rid of the need of high frequency oscillation. So good suggestions, but not practical for me in the middle of the night to try and move this child to a smaller to a hospital with a PICU.
Another suggestion is nitrous.
Good.
Nitrous.
I'm glad someone said nitrous. So what is the main side effect of nitrous? So you suggest nitrous because you have high pulmonary pressures, so you want to drop the pulmonary pressures. Does nitrous only drop your pulmonary pressures? The answer is no. So it's a potent vasodilator, and this is a child who was already predictably coagulopathic, and pulmonary edema manifests with essentially bloody, frothy secretions. So if you give nitrous, those secretions will get more bloody and worse, and you will also vasodilate her. So the chances of her on arresting with using nitric are quite high. So in this context, I opted not to use nitric, but with those sort of numbers, it's a considerable concern for the team that she will not survive if she was to go to a conventional PICU. So you need a PICU that can do ECMO. So we had to make sure there was an ECMO bed available for us to take her to. Otherwise, she was unlikely to survive because she was on maximal ventilatory therapy at that time with poor oxygenation already and an awful X-ray. So it's important to, you can be clever about it and calculate the oxygenation index, which is not hard to calculate. But if you are needing a PEEPs of 15 on 100% oxygen and you can't ventilate, then on balance, you need to think of ECMO and push for getting an ECMO bed, really. Otherwise, she's likely to not survive in a conventional PICU. Okay, so any questions on that?
Would so a suggestion is coming here. Would you try and hand ventilate until ECMO available?
That was a distinct possibility. The thing is with hand ventilation is that you can deliver the same breaths on a ventilator. You just don't want to see the numbers. You don't want to see that you're giving a 50 on 20, which is going to completely mess up her lungs. So you can do that through the machine. So, you know, I'm a big fan of hand ventilating, but actually the machine can generate. It's just going to tell you the truth about how dire the situation is, if that makes sense. Because the Hamilton, which is what we use, can't deliver those pressures. It's whether you want to look at those numbers or not. So I think it's a bit of a willful blindness if we hand ventilate them because we can't put them on the ventilator that can deliver those pressures anyway. Right, in the interest of time, I need to move on.
Can I ask a question? Sorry, Costas. Was there
Yes.
pleural effusions?
There were no pleural effusions. They were
That
just
would obviously be
significant
some-
pulmonary edema with severe ARDS picture on the X-ray. We did a point of care ultrasound. There was a tiny bit of fluid, but nothing worth draining. She did end up with more effusions later because she had a lot of fluid, but not during the acute presentations. So let's move on to our circulation plan in warm shock. I'll be quick because it was touched upon by Tom. Good. So you know your warm and cold shock. I know it's not used a lot, but we all know what we mean by talking about warm and cold shock. So although imperfect, I quite like using the terms. So like Chris said in his own presentation, if you're not a specialist, adrenaline is quite a forgiving drug. It's on the guidelines as a first point for a reason. People are comfortable using it. So there's absolutely nothing wrong with starting with adrenaline and then adding other bits in. You just then need to decide what the best parts to inotropes are to add in. And NORAD is the go-to drug because you need more pressors. She's vasodilated. You need to vasoconstrict and squeeze her a bit more. So that's a good drug to use. And then third line is vasopressin. Now, as per the international consensus paper, and as per her blood sugar that we knew earlier that it was low normal, she was always likely to need hydrocortisone because she's getting it after 2 inotropes. You are formally into the catecholamine resistant shock arena, and therefore you need to be drawing up your hydrocortisone and giving it. But we knew she was likely to need this from the beginning, and that's why that first gas is important. And even the normal numbers tell their own story. So be aware of what the so-called normal numbers and pay attention to them. So take-home message: once we reach the 2 inotrope threshold, get your steroids out. Now, I like blood products because they are useful volume. She had a lot of blood products because she was severely coagulopathic. So she got blood, she got platelets, and she got fresh protein plasma. I do not like saline, and that's been touched upon before. We have a child with severe acidosis, and we need as normal physiological parameters as possible for our inotropes to work. If your pH is less than 7, none of those inotropes are going to work very well at all. So by giving pasta water, which is acidic, you're going to confound that acidosis further and make the pH much worse, thereby causing detriment to this child. So if you must use colloid before the blood products arrive, do not give something acidic, give something basic. And both Hartmann's and Plasmolite are basic solutions. There's a few areas of misinformation in respect to Hartmann's, whose other name is Ringer's lactate, saying, oh, we can't give lactate to this child. That is not based on evidence. The lactate that is in Hartmann's is metabolized by the liver into bicarbonate. So it's not an acid. Physiologically, it's a base. Giving Ringer's lactate does not increase a child's lactate. Okay. The other aspect of this is that she's already hyperkalemic, and significant acidosis drives potassium from the intracellular to the extracellular space. So by making her more acidotic and by giving blood products at the same time, you're going to cause a further hyperkalemia. So try and achieve a pH above 7.15 ideally, and try and avoid saline because that will only take your pH in the wrong direction. Okay. Any questions on that?
Sorry, we don't have a question on that, but we did have a question about your ventilation strategy.
I'll address that at the end probably because we've moved past from B. While I'm on circulation, I'll touch upon calcium. So critical illness, especially septic shock, comes with critical illness hypocalcemia. The best way to check our calcium, again, is on ionized calcium. That's the free calcium we have. And these children really go through their calcium very quickly. Calcium is known as the hidden inotrope, so make sure you stay on top of it. So generally, most people try to aim for an ionized calcium of more than 1, more than 1.1 or thereabouts. So if it's dropping below those numbers, keep checking and rechecking. And if you've given it once, don't forget about it because it will drop again. So Chloe needed 3 lots of calcium gluconate in a space of 2 or 3 hours for it to stay above 1.1. So always keep an eye on the calcium because drugs, again, need it to work, and it does work well on the myocardium. So don't forget it. And if you've given it, remember that you might need to give it again. So remember, Chloe injured her head. We think is superficial, but we have no means of proving it, and she needs to go to an ECMO center. So what are we going to do? Are we going to risk taking a very unstable patient through to CT, or are we going to pick and run and go to the ECMO center anyway? It looks like the majority have been cautious and decided not to CT her. I'm disappointed in people choosing propofol because we just said that propofol is a potent vasodilator, so we shouldn't use it in kids with significant sepsis. So put the white stuff in the bin for this case, and rely on good and tested morphine and midazolam for now. So generally, you don't need a CT to make you eligible for ECMO, but because you had a head injury and because children on ECMO are anticoagulated, no ECMO center would accept her unless we cleared her head with that story. Because if she had any intracranial mischief or injury, if they had anticoagulated her, that would have made things worse in terms of trauma. So we had to make sure there was no intracranial bleed. So we had to take a very sick, very wobbly patient on 4 inotropes and very high ventilatory pressures, who was hypoxic, to CT, just to prove that she was, whether she had an intracranial pathology or not. And thankfully she didn't, but it wasn't a pleasant experience. But otherwise, she would not have needed a CT if she didn't have that complex history to go with it. In terms of neuroprotection, we've touched upon these on previous slides. It's important to do the basic things well. So ventilate, aiming for normal oxygenation, 88 to 92% is what the evidence shows for these children is fine. CO2 ideally needs to be between 4.7 and 4.8. Ideally, don't let them become pyrexial. Try and bring the temperature down to between 36 and 37 is a good sweet spot. Don't let them go hypoglycemic, and aim to have a normal blood pressure using fluid and inotropes, essentially. If you can elevate the head to 30 degrees, then do that. If there was any concerns of seizures or anything like that, then I would have given her some Keppra, but at the time there hadn't been any, so I opted not to give her Keppra at this point. And I think this is our last slide, and we've touched upon it with Tom. Let's see if you were paying attention. Yeah, okay, good. Some good answers. Right, so IVIG has in sepsis has in barn door sepsis doesn't have a role to play. However, the international consensus states that IVIG, specifically in toxic shock syndrome, so toxin releasing diseases, does have a role to play, and if available, we should give it. Okay, it can change the disease trajectory. Sometimes it works, sometimes it doesn't. About 20 years ago, before the pure version of IVIG was available, we used to give fresh frozen plasma because that has diluted immunoglobulins in. So she had that as well. But thankfully, we did manage to give her some IVIG and get her hands on it. Half the battle is convincing the microbiology team to unlock their safes and give them to us, because it's a very precious resource and we don't have the stores required in the UK post-Brexit, unfortunately, so it's harder to get hold of. But if you can, it's worth asking the question. Problem with IVIG is that it's a blood product. It can be anaphylactogenic, so you need to give it slowly and be ready to respond, because sometimes they will drop the blood pressure, especially if you give it faster than you should. So be aware of the side effect profile, but it's generally a good drug to use in toxic shock syndrome in the context of sepsis, but it's not appropriate for every septic child by any means. And obviously, because we're thinking about toxin releasing bugs, clindamycin is important because that can mop up the toxin and stop the toxin production. Okay. And it's more important to give Clinda than IVIG. So this is what we did with Chloe. This is a real case, and we have consent from the family to use Chloe's real name. So we used a cuffed T tube. Because of all the blood that was coming up from a tube, she was increasingly harder to ventilate. And we used some nebulized tranexamic acid and adrenaline to try and mitigate that. The evidence for nebulized tranexamic acid is anecdotal. There's no high quality evidence but anecdotally it works very well. And there are a few papers looking at children with post-adenotonsillectomy bleeds and adults with hemoptysis and pulmonary bleeding that shows that it works. And so for under 25 kilos, the dose is 250 milligrams nebulized, and over 25 kilo children, we give 500 milligrams nebulized, and it did work quite well. We employ a high PEEP strategy with a long eye time. We avoided nitric, and very importantly, recognized the need for ECMO. And I can guarantee you that if Chloe went to an ICU without ECMO, she was unlikely to survive staying there, and there was no need to expose her to more risk by moving her to a second PICU afterwards. In terms of circulation, this is before dopamine was phased out. So she had been on 4 inotropes plus steroids, and we gave lots of calcium corrections. We CT'd in scan, and during scan, we were worried that she showed signs of raised ICP because she became quite hypertensive and bradycardic. So we gave some hypertonic saline, but there was nothing on the CT suggesting that why she should behave something like that. We gave KEF, Clinda, cyclovir, and IVIG, and got lots and lots of volume, most of which thankfully was blood products. And unfortunately, she had already had some saline before we got there. And this is her. She spent 11 days on ECMO, came off ECMO around Christmas time. And this is her 2 years later celebrating her 8th birthday riding on a unicorn. And that is the talk. So these are some more resources about Chloe's case and about where we got our material from. And that's your feedback code on the screen. Thank you for listening.